It's my honor to introduce Dr. Stewart. He'll be speaking to us this afternoon about the current status and future direction of the ACS Committee on Trauma Verification Program.
Thank you. It's a pleasure to speak again. I'd like to say thanks to you, PJ. Thanks to the whole team for the Arizona Trauma Association. It's been a great privilege to be here. Do I need to push something? Okay. The screen, the monitor's not working here, but we're good. So I'm going to talk about a quick overview of the history of the Verification Review Committee. As I talked about yesterday, it's really unique in a way that the people who are providing the care are actually self-regulating themselves, and that's really the process. So I'm going to give a quick run through the history. To give the history of the ACS COT or the Verification Committee would take a long time, so I'm going to use a who, what, when, where, why, how approach to it to quickly run through the history. The ACS model for healthcare quality has been to set appropriate standards, that ensure the right infrastructure, that use the right data, that get the right monitor on, use the right data and verify. This has actually been taken on by the American College of Surgeons as their approach to quality and healthcare reform, and that was all pioneered by the Committee on Trauma. Thank you. So, getting right to the history. Who? Well, it's actually you. Surgeons, physicians, nurses, EMS professionals, public health and EMS officials working through the ACS Committee on Trauma. These people and their generation were particularly key. So this is Erwin Thal, Frank Mitchell, Norm McSwain, Don Trunke, Jerry Shafton, and David Root. A small group of people really started the verification process and really made it a reality. But working with a group of people like your friends and neighbors, professional neighbors, really have made this possible. What? Well, it's simple. The development of the concept of a trauma center and the criteria for a trauma center really was very disruptive innovation. Then, once that was done, they developed the principle of getting these trauma centers to work together with themselves and with EMS, and then this has been expanded to other emergency healthcare conditions. When the past century is when this development has occurred, I'm going to give a quick spot for 1913, 1950, and where we are today. 1913. That's my grandmother. My grandmother was born in 1908, so she was 5 years old in 1913. What was going on in 1913? Well, the American College of Surgeons was founded. The income tax, the 16th Amendment, was passed. Women did not have the right to vote. They didn't have the right to vote. Women didn't get the right to vote until 1920. Woodrow Wilson was president. The Panama Canal was completed. The Federal Reserve was created. R.J. Reynolds created its first packaged cigarette. Richard Nixon, Rosa Parks, Jimmy Hoffa, Vince Lombardi were born. What was it like to get hurt in 1913? The mortality for an open femur fracture was 70%. A 70% risk of death with an open femur fracture. If you had a gunshot wound to the abdomen that penetrated the peritoneal cavity, it was a 90% risk of death, and a total body surface area burn of 30%, 50% of those patients died. 1950. In 1950, the Committee on Trauma was renamed itself from the Committee on Fractures to the Committee on Trauma. I showed you this yesterday. This is a car crash my mom was in July 24th, 1950, or July 23rd, 1950. What was it like in 1950? Well, really not much had changed from 1913. There was no trauma system. There were no automobile safety systems except for mass of the vehicle. Ambulances were operated by funeral homes, a little bit of a conflict of interest, which direction do you turn? There were certainly no hospital criteria for injured patients, no ICUs, no special surgical teams. But really from 1950 on, the group working with others basically transformed trauma care and prevention and really pioneered that ACS model for quality. The 60s really started to see serious advancements. There's no question that the National Academy of Sciences white paper was a key plus forward. That if you look at that very short document and read it, it outlined what would become EMS, emergency medicine, trauma surgery, and trauma centers and trauma systems. Very important. In 1976, in the Bulletin of the American College of Surgeons, the first criteria for trauma centers were published. The people who did this knew about quality improvement. They knew about the work of Ernest Codman, who did his initial work in 1916. They knew about the Joint Commission. They had helped to found the Joint Commission from the American College of Surgeons. And actually, the Medicare-Medicaid conditions basically required accreditation of hospitals. They probably knew about the work of Dr. Donabedian, Structure, Process, and Outcomes, landmark. But in 1976, they set the criteria for what a trauma center should be. And initially, public hospitals were the de facto trauma centers. From 1976 forward, you started to see these trauma centers working together, working with their EMS agencies, developing trauma systems. Where? Well, clearly in the United States, this concept of a trauma center and trauma system is really well established. Canada, it's very well established. In certain parts of Western Europe, it's established. But now you see trauma systems and trauma centers developing in the less developed world. And there's a current pilot project going on in Latin America looking at a potential verification program for Latin America. In big cities all across the U.S., it's very common. In fact, it would be extremely rare to not have a designated trauma center in larger metropolitan areas. But you've seen trauma systems expand out to rural areas like far west Texas. And like I said, you see it now in the developing world. I believe in the next 10 to 15 years, you will see trauma centers and trauma systems throughout the entire world. The goals were very simple: to improve the care of the injured patient, to reduce complications and death, and now to respond to wide-scale events such as disasters. How? We talked yesterday about how, using a professional model, you got people in a room working together, encouraging them to talk, and they discussed, redefined, rediscussed, developed criteria by consensus, and then they partnered with state health agencies, so the rules that they came up with as professionals then became codified into statute, which was a key thing. I've talked about this already, a summary of how set standards that ensure the right infrastructure, use risk-adjusted clinical data, and verify. If you look, we've gone from no standards to trauma center criteria, the optimal resources document, to verifying that trauma centers meet those criteria, to now integrating process, structure, leadership, and outcomes, and international verification. What about the future? Well, key point is, if you look at what happens with respect to healthcare research, it's been well recognized that there's a large lag, there's a time delay between when something becomes known, when, for example, statin use is known to be effective, between when it gets implemented. So in a way, the verification program, although that was not its main intent, is a way that accelerates from evidence to implementation, really makes a real difference. So this next part of the talk, I'm going to try to I'm going to try to make it clear to you where we sit with the COT with respect to planning what might happen so that you have a good understanding. And actually, I want your feedback. I want your input with respect to it. So three quality programs within the COT evolved in a way separately. There's the Verification Review Committee, i.e. the committee that verifies trauma centers, the Trauma Quality Improvement Program, which is a risk-adjusted benchmark to assess how trauma centers do relative to each other, and the Performance Improvement and Patient Safety Group. There's been a really diligent effort to get the VRC, PIPS, and TQIP to work together. It's been a big effort over the past 2 years. We think this is better for the patient. We think it'll be better for trauma programs and better for trauma centers that PIPS, TQIP, and the VRC all work in lockstep with each other. Think about it in a way like car design. Every part of an automobile is designed to seamlessly work together and fit together. That requires having an integrated design and manufacture process, and so we take it for granted that our cars work great. If you think about the integrated trauma quality, the VRC, PIPS, and TQIP. This is my view of this. The VRC program is in a way in the analogy of manufacturing and designing a vehicle, where PIPS is essentially the drivetrain of quality. It's the way in an individual trauma center that you move things to fruition, and TQIP is the dashboard. TQIP is a dashboard that gives information about how the car is doing. From 1976 to 2014, we're currently in the 6th iteration of the resources for optimal care of the injured patient. And I have a little bit of trepidation because there's so many changes in it, but I'm going to walk through some of those changes, for I know there's probably a fair number of trauma program managers in the room. I'm not going to get anywhere close to all of them, but I'm going to cover some highlights. The latest iteration of the Optimum Resources document was released in October 2014, and trauma centers started being verified under these criteria July 1st, 2015. First, with respect to trauma center levels, there was efforts throughout the entire standards document, through the Optimum Resources document, to level up level 1 and 2. The ACS and many state systems have said that the clinical care at level 1s and 2s should be roughly equivalent. It's not the same, but it should be very close to equivalent. So efforts were made throughout the Optimum Resources document to level up that care and to make certain that the level 1 and 2s were the same. The other thing is that in addition to emergency department response for surgeons, response to other areas of the hospital, particularly the ICU, are emphasized. For inter-hospital transfers, there's now much more detailed requirements for when patients are transferred to document how that happens and to document the process, the way patients get transferred. This was done because in a number of areas of the country, getting patients transferred seamlessly back to definitive care is a critical issue. General surgery changes for the document. There's not a lot, but we clarified the response time for the highest level of activation. Immediate was, we tried to basically use 15 minutes with an 80% threshold. We tried to articulate exactly what the response times were throughout the document. Emergency medicine board certification has been required, but the presence of an emergency medicine physician in the emergency department is spelled out in the Orange Book in the Optimum Resources document, where it had not been clearly spelled out before. So in level 1s and 2s, the continued presence in the emergency department is key. A key change was in orthopedics, that the leadership of, in a level 1 trauma center, the leadership of orthopedic care must be overseen by an orthopedic surgeon who's completed a fellowship in orthopedic trauma care. With respect to, there were a number of changes with respect to what in the document outlined collaborative clinical services, so ICU, anesthesia, radiology, and that the timely response times to the ICU is now monitored for, not just for the emergency department, but also for the ICU. And the criteria for a liaison to attend 50% of multidisciplinary peer review meetings was emphasized. And for general surgery, there used to be core and non-core faculty. Now the core and non-core are the same, and everyone has to have a 50% attendance at those meetings. For advanced practitioners, PAs, nurse practitioners, and other advanced practitioners, if those providers are providing care to the emergency department, they have to be current in ATLS. With respect to PIPs, probably one of the biggest changes in the Orange Book is the requirement to use a risk-adjusted, risk-stratified benchmarking system to measure performance and outcomes. And you're the first to hear this. New York Region 2 may have heard it just a little bit before us, but to move to that integrated quality program, we're adjusting this criteria to basically say that all trauma centers must use a risk-adjusted benchmarking system to measure PI, and this should be ACS TQIP. And but there will be a grace period and up to January 1st, 2017 for those not using ACS TQIP, but after January 1st, 2017, all programs will need to be enrolled in TQIP. With respect to Chapter 16, the performance improvement and patient safety, remember the engine that drives quality in trauma centers. This was extensively revised and really fully rewritten and clarified. This was not in the Orange Book, but this is our current view of how the Orange Book will be revised. So the criteria have been published. We're currently in an implementation phase. We will soon be actually reaching out for stakeholder input from all ACS verified trauma centers, the liaison organizations that are key to trauma systems, so state EMS organizations like NASEMSO, like the Society for Trauma Nurses, like the American College of Emergency Physicians. We will reach out and request feedback on these criteria. They will then be reviewed, a draft will be produced, will be re-released for final input and revised. We think this can be done in a 4-year time period, potentially even sooner, with the goals to continually improve the document, not totally rewrite the document, to use incremental changes, not radical changes of the document, to simplify where possible, and to make it data-driven, and to figure out how to incorporate outcomes. So what about the future of trauma center verification? If you were to talk to surgeons on the COT and you ask them which is the most important, process structure and leadership or outcomes, I think you would get a range of opinions that would probably be centered in the middle, but on both extremes you'll have people say that outcomes are clearly the most important. On the other side of this, you would get surgeons and nurses who would say, well, the way you get good outcomes is with good process structure and leadership. So you'll get a range of opinions. We've never incorporated outcomes into verification other than chart reviews, but with the risk-adjusted benchmarking program of TQIP, it's clearly a move to incorporating outcomes as well as process structure and leadership. This is the current way that verification has been done, so that if an individual trauma center has good processes, good structure, has a good verification review visit, that center was verified without weaknesses or without criteria deficiencies. We never had outcomes to determine what outcomes were. So if you think about it, if you had good risk-adjusted outcomes but poor VRC processes, you wouldn't show up. You would basically, that trauma center would not be verified, but outcomes clearly important. So what's going to happen with respect to this? It's not entirely determined, but here's what I think will happen. Obviously, if a trauma center has good risk-adjusted outcomes and a good VRC visit, they're going to be verified. Obviously, if a trauma center has poor VRC visit, poor VRC outcomes and structure, and poor risk-adjusted outcomes, the trauma center is not going to be verified and is going to receive criteria deficiencies. But if a trauma center has good VRC processes and structure, but risk-adjusted outcomes are low outliers, then what's likely going to happen in the beginning, that center is going to be verified, but it's going to basically need to follow and implement an approved COT performance improvement in patient safety and implement TQIP best practices. In the bottom left corner, the similar process, what we think will be a rare center that has good outcomes, but a poor VRC visit. Similarly, that center will likely follow the same course. So summarizing, the American College of Surgeons Committee on Trauma's Verification, Review, and Consultation program pioneered the ACS's quality improvement model. That model has been associated with an improvement in mortality and a reduction in complications, and that the current iteration of the Optimal Resources for Care of the Injured Patient, the Orange Book, emphasizes trauma systems, standardized care between level 1s and 2s, incorporated a risk-adjusted benchmark. Moving forward, the concept of an integrated quality program that ties the VRC to PIPs and to TQIP is definitely going to happen. And that revision of the Optimal Resources document will move forward with that integrated quality program, but also with input from stakeholders like you in the audience. I'm happy to answer any questions.